All right, everybody. Let's get going to our next session, which is Global Case Studies for Cervical Cancer. We have two outstanding speakers today, Dr. Isabel Scarinci from University of Alabama at Birmingham, and Dr. Kathleen Schmaller from MD Anderson Cancer Center. And so they will both be talking about their experiences leading efforts that either within statewide and maybe beyond that, as well as in between countries. So without further ado, I'll introduce Dr. Scarinci. So she has a PhD and an MPH, is a behavioral scientist and professor in the Department of Obstetrics and Gynecology at the University of Alabama at Birmingham, where she serves as director of the Division for Global and Rural Health. She has dedicated her career to cervical cancer prevention and control among underserved populations in rural U.S. and low and middle income countries, and she'll be talking about her efforts in Operation Wipeout. Let's welcome the speaker.
Thank you, and thank you for the invitation. Thanks, Rebecca, for the invitation to come here. I was gonna come yesterday, but I told Rebecca it was my husband's birthday, and I would not leave my husband by himself on his birthday. So, I am, who here in this room has been touched by cancer? Directly, indirectly, through a neighbor, family member? A lot of us. But there is only one cancer that we can eliminate, and that is cervical cancer. That's why we're so passionate about. At the Cancer Center, and I'm sure this happens to Kathleen as well, people say, when we're gonna find the cure for cancer? And I say, I have a better deal for you. There is one we can get rid of. And that's what I'll be talking about. And the global here is Alabama. So, and that's where we're doing Operation Wipeout. So Alabama, this jumps. So I am in a poor state. It's interesting. Life throws some curves for you because I am originally from Brazil. So this is not an Alabama accent, although I have been in the South for 36 years. So I grew up in a rich state, in a low-middle-income country, and lived most of my life in a poor state, in a high-income country. So those are the things that we need to think about when we think of global and rural health. So Alabama does experience a high burden of cervical cancer, and the mortality and incidence is higher in rural counties, and then we also get advanced stage. So some of you do not work on, this is gonna be interesting. So why can we talk about elimination? It's when a lot of you, as I'm a behavioral scientist, so I don't develop the technologies. What I do is get them where they need to go and get them to the underserved populations. But people like you made the discoveries that today we can talk about elimination. And it's when it was discovered that HPV is the main cause of cervical cancer. And with HPV being the cause, opens door for the development of the vaccine to prevent cervical cancer, HPV testing to detect changes even before of cytology, and technologies in terms of treatment, that she's the expert, not me. So, but most of us will clear the virus, and if the virus persists, develop cervical cancer. So there are many entry points that we can intervene. And that's why, because we have a vaccine, we understand the natural history of cervical cancer, we have good screening, and we have good treatment. WHO can launch the plan to eliminate cervical cancer. 4 pillars: prevention, screening, follow-up, and treatment. And so, in this country, we do have those tools. We have HPV vaccine. It's free in this country, either covered by insurance or the Vaccines for Children. That's a federal program. We have screening at Texas, like Alabama has the Texas Breast and Cervical Cancer Early Detection Program that will cover screening for women who are uninsured. And also, at least in Alabama, they navigate them through Medicaid unless they are documented, undocumented, so then it's a bigger challenge. So why we still have a problem in this country? So that's when we came together in Alabama. And this is really a group of organizations, not only an academic center, but the Department of Public Health and Rotary clubs, a civic organization that has really is international. And if we eliminated polio in the world today, it's because of Rotary clubs that work on that elimination. I had polio, if you saw me limping, so I know we can eliminate another disease if we did one. So we launched the plan in Alabama on 3 steps: HPV vaccination, screening, and follow-up. And it's not led by one organization, but everybody owns it. And we came together, brought providers from all over the state, and they came up with the plan. But we knew that if an academic center launched it, no teeth. If Rotary launches it, no teeth. So we went to the state health officer and said, you need to launch this plan. And I was ready to argue with him, and I had all my list, like when you fight your AT&T bill, you have all the arguments. And he immediately said, yes, why not? And then Alabama today is the only state and the first state to have an official plan to eliminate cervical cancer, bringing people together and not a dime on the table, totally unfunded. From a pot of money. Every year, you're going to hear more about it, how organizations then, if an organization want to be a partner, what they bring to the table. And that's our goals, very small. And this is very, very comparable to the plan for the World Health Organization. You see, if we increase vaccination to 80%, get women screened, 90% of women, and 9% of women treated. I don't know at MD Anderson, but at UAB, a tertiary center, 40% of women who have an abnormal cervical cancer screening do not come for follow-up. 40%. So, and in rural Alabama is even higher. And then we got partners together. Those are a lot of our partners. They come from Rotary or public health, but the role of the Alabama Department of Public Health has been critical in this effort. And this is a video that you have the link there that CDC commissioned about the example in Alabama. And it is, sorry. Okay. So, and then we started, but we're not prepared. So these are some, and like this Conquering Cervical Cancer, it's a documentary, if you haven't seen, on PBS, it's streaming on PBS. It features us, but it also features the work of Dr. Schmeller here in Texas. It's an amazing documentary of the work with underserved populations. We have these billboards all over the state of Alabama, that was paid by immunizations. We didn't pay a dime. I don't even know how much those cost. And we start getting the word out in terms of awareness. And I'm going to highlight just some of the. But this effort, we didn't want to do it like you only look at your belly button. We said everyone can play a role. If you're a dentist, you see, if you are a policymaker, if you are a Rotarian, if you are a business owners, what can you do? And we developed those handouts and start engaging everybody. And then the champion starts, I want to do it. My Rotary Club there in this small town, I want to do something. What can I do? Then we develop tools, and we start training them to be champions, not to be experts in cervical cancer, but how to be champions in their community and equip them, but everything that's evidence-based. And these are things like we train them on motivational interviewing, and they have all these handouts and all these tools that they can go out in the community. So I want to highlight some of the successes, and then we can address more in the questions. So, of course, one is we need to increase awareness. Cervical cancer can be eliminated. So that, a lot of people did not know that. Engagement of Rotary clubs has been phenomenal across the state. And then colleges and universities, here is the students, the Operation Wipeout at UAB, they established a club. How to educate providers across the state to adhere to guidelines. I don't know Texas, but a lot of our providers are not adhering to guidelines. And also increase access to screening and HPV vaccination at the Public Health Department. But this has been a game changer. A lot of women in rural counties would need to go to Birmingham or Montgomery for follow-up. Now, Alabama Department of Public Health trained nurse practitioners to go and do the follow-up where they are screened. And that is the number of screens they have done in 2025, 1,000 screenings. And their no-show rate used to be 70%, and now their show rate is 80%. So just a simple thing that they have done. And this is the one I wish the high school students would hear about. This is the county, Chambers County, the county with the highest burden of disease in Alabama. The cervical cancer incidence in Chambers County is the same as Guatemala, Nicaragua. And we work with the Rotary Club there, and the high school students develop a program, a campaign, and then that was very successful. And they develop a toolkit for other school systems. This is an activity book that they work with middle schoolers. And we got one school, they got vaccination up to 81%, and the other 65% in a county where vaccination was 35%. This I need to show you. They had a parade last week, and they won first place. And this is small town, but that is what it's about. So it's those high school students educating their communities, and we have Captain Vaccine there with a surfboard. So this is my last slide. I just want to say, how did you do this? So this is the summit we had last year, and the Rotary Club of Birmingham said, we will host it. How many people you think will come? I said about 50 people. Well, we need to stop registration at 150. And those are all champions that said, I want to do something in my county. I want to do something in my town. And so really, we're not ready. We didn't think was going to have that much impact. And the champions, as the last panel said, I don't know here, trust has been a huge issue. Before, when I started doing this work, a lot of mistrust in healthcare was an African-American or minority issue. Not today. They don't trust healthcare, but they trust those Rotarians. They trust those community leaders. And those are, when we go to those towns and counties, we say, we have financial planners who are champions. We have a woman who make wood pallets. So everybody can, as long as then they adhere to the accurate information. And they bring unique perspectives and connections and resources. And the first thing we need to do with them is you need to understand the landscape. Where are people going to go for care? Because what good does that do if we educate and they don't know where to go? And always focus on the mission. And I can tell you, I'm toward the end of my career, this, as all the publications I have had, all the millions of dollars that I have had from NIH, this has been the most rewarding thing I have done in my career, because I see the power of people. And I think that for us who rely on grant money, I have relied on grant money for 30 years, it's better when you don't have the money. Because then they say, I don't have it. Because when you have it, they say, oh, you have the money, you do it. this has really been amazing what people bring together. Yep. And now, I think it's not here, but now we are, a lot of states are coming to us for advice. The world, now my plan is that, my dream is that Rotary International will pick cervical cancer as the next polio. Because polio, we are almost done. 64 cases last year in Pakistan and Afghanistan. And that will be phenomenal because now we have the tools for lay people to be able to do that mission and show that they can eliminate a disease. Because I grew up going literally door to door, same area, the south of Brazil. I had polio, I was 8 months old. And my mom would take me door to door, literally, in shorts, with the vaccine, and would say, you don't want this to happen to your child. So I was the star in the region. And when she died of metastatic breast cancer, and I asked her, I said, Mom, did you ever think we would eliminate polio? She said, no, but I did my part. And I think cervical cancer, that's what we all can do, because we are today, we can have the best technology. You can develop the best technology here at Rice. If it doesn't get to the hands of the ones experiencing high burden of disease, it's exactly like my publications on the shelf. You know, somebody asked me the other day, I have a lot of awards in my office. She said, what you're going to do with those when I retire? When you retire, I said, you go to the garbage can. Because it has no... So that, and it will. Who will take those? So that is what we need to do, and that's why I believe in it. Thank you.
Yeah, really inspiring story. I think it was just World Polio Day last week, and Rotary had an event. I think they gave 3 billion vaccines since they've started this as their main cause. So hopefully they can finish there and move on to the next one. Great. So next we have Dr. Kathleen Schmaller from the University of Texas MD Anderson Cancer Center. She is a professor of gynecological oncology, and she provides care to patients with gynecological cancers, including surgery, chemotherapy, and preventative services, both at MD Anderson and the Lyndon B. Johnson Safety Net Hospital. She's also the Associate Vice President of Global Oncology for the MD Anderson Network, working with ministries of health, UN agencies, international organizations, and other academic centers to improve cancer prevention and treatment services globally. And she will hopefully tell us a story about Avanso, am I saying it right? Consortium, that she is co-leading with several others. So let's please welcome our next speaker. Thank you.
Thank you, Kevin, and thank you, everyone, for coming today, and to the team at Rice for inviting us to talk about this. It's always hard to follow Isabel, but really very inspiring talk, and so great to work with you and to be here with you today. So I'm going to talk a little bit about our work in Mozambique and in Brazil, and a little bit at the end about Texas as well. But just to take a step back about cervical cancer, you can see here the countries that are in the darker colors. Blue is the incidence on the left, and then the deaths on the right. And it's, very, very, the highest rates are in low-resource countries, and primarily in sub-Saharan Africa, Southeast Asia, Latin America. But the important thing is we don't have to go all the way to Africa to see a lot of cervical cancer. The states in red have the highest rates. Our states, Texas, Alabama, are not doing well. And then there's regions within those states, like the Rio Grande Valley that we heard a lot about before, where the rates are really, really high, similar to Alabama, as high as some of the countries in Central and South America, or even in Africa. and we really don't even have to go all the way to the Rio Grande Valley. I work primarily at LBJ Hospital, and we see on average one patient a week, a new diagnosis of advanced cervix cancer, and that's in one of the richest cities in the world with our amazing medical center and MD Anderson as the largest cancer center. So we don't have to go very far to see cervical cancer. So although the rates are much lower in the US, in some pockets they're as high as low and middle income countries. As Isabel said, cervical cancer is completely preventable. We know how to prevent it, we know how to treat it, we know how to cure it. The great work of Harold Zerhausen and others that made that connection, that it was caused by HPV or the human papillomavirus, quickly followed by the development of a very, very effective and very, very safe vaccine against HPV. But we have 2 to 3 generations of women who weren't eligible for the vaccine and had already been exposed to HPV. But we have great screening. We now have HPV testing, as Isabel said, and now we can do self-collection, so we've made it even easier. We had the Pap test, or still have the Pap test, but that decreased the cervical cancer rates by 60 to 70% in the US since the 1960s. I mean, it's been a huge success story for the people who had access to that screening and follow-up treatment. And then if we find precancerous cell lesions, we can treat them, and there are procedures that can be done in the clinic, some of them even in a mobile van. So really nobody should be dying of this disease if everyone can get the access that they need. The biggest problem with it is, as I said, we've decreased the rates so significantly in the US and other high-resource countries, but that requires a lot of visits. So in the US, a patient comes for screening with primarily HPV testing and or Pap. If it's abnormal, we call them, they come back, and they get colposcopy with cervical biopsies. And then if they have high-grade precancer, they come back for a 3rd visit where they get a LEEP or cold knife cone, or in other countries can get ablation. This works really, really well. So why do I see a new patient with advanced disease, every week at LBJ? And it's because people can't do this. People aren't going to come back for all these visits, either because they don't have money, they don't have insurance, or they're scared, or they're asymptomatic, so they don't know. And usually these women are in their 20s, 30s, 40s, 50s. They have children, they have a job, they're taking care of aging parents. So a lot of people get lost. The other problem with this is that you need laboratory or pathology services at each step. And in many countries, it's just not available. And so, kind of the 2 sides of it. If we're going to do a test, we need to make sure we have the lab and the resources to read it in a high quality and with a quick turnaround. So again, this has worked really, really well. Cervical cancer is not even in the top 10 in the US anymore because of this system, but just a lot of people fall through the cracks. In many of the low and middle income countries, people just don't have access to any screening. What we see more in the US is that people get screened because it's also part of prenatal care. So most people get a Pap or HPV test at some point, but then they get lost after that. And so when we talk to our patients who come in with advanced disease, they're like, yeah, 10 years ago I had abnormal screening, but I was pregnant, so they weren't going to do any procedures during pregnancy. And then once I delivered, I lost my insurance, or I had a new baby, or I forgot about it, or I was scared and just didn't come back until I had symptoms and was bleeding. So that's kind of the reality of what we see. So to address some of these issues, I was very fortunate more than 10 years ago now to meet Rebecca and the team here at Rice. And really to work together on trying to address some of these issues. One very important one is a point of care HPV test. So as I said, when we do the HPV tests now, we don't get the answer right away. So the patient has to be called with the results and come back, and that's where we're losing a lot of people. So Rebecca and her team, you can see many of the students here, for many, many years now, have been working on many different versions of point-of-care HPV test. And that means that the test can be run in the clinic or the mobile van, or it doesn't have to be sent off to a big lab, because the technology to run it is simple and can be run by the folks in the clinic. And most importantly is that we get an answer quickly. So great would be like a pregnancy test where you get it, in seconds or a minute, but even within an hour, we can have the patients wait and do that. And I just want to give kudos to the teams, and you can see here they recently had a publication in Nature Communications that really, really moved this forward. And I will tell you that people all around the world keep asking me, can we get the rice test? Can we use the rice test? So there is an unbelievable need for this. And not just in low and middle income countries, the Rio Grande Valley, everywhere. I mean, everyone would love to have this test so that we could save women these multiple appointments, but also, not lose them and help them get the care that they need right when they come for that first visit. And then kind of addressing that next step where if it's abnormal, if they have HPV, not everyone needs treatment, so kind of figuring that out and triaging it. And the traditional way is to do colposcopy, where we look at the cervix with a microscope and take biopsies. But again, we have to wait for the results. So Rebecca and her team have done a lot of work on high-resolution microendoscopy and multimodal imaging to be able to do kind of a visual biopsy, so that we don't have to, actually take a biopsy, which is uncomfortable for the patient, but then have a pathology lab that can process it and a pathologist that can read it. So these devices help assess the morphologic features that a pathologist normally looks at: nuclear to cytoplasmic ratio, nuclear size, atypia, and then the teams have done a lot of work on automated algorithms and using AI and machine learning to be able to give us those answers. So again, kudos to the team. Some of them are here. Many of them have graduated. I've been on a lot of committees and seen lots and lots of students who have come and really helped move this work forward. And so how does the work that you do here at Rice fit into what we do at MD Anderson? So we have a program for reducing cervical cancer. Lots of folks from our team are here today. And we work in several areas, but in policy and advocacy, in research, we obviously do a lot of research, and then in training and education. And I love this slide because it shows members of our team in many different scenarios. So on the left, I'm teaching LEAP in Zambia. In the middle and the top, Mila Salcedo, who runs our educational programs, who's here today, and many of the Rice students know her, is with a group in Indonesia. And then some more pictures from Zambia. And on the right is in Texas. So we do a lot of training of providers, nurse practitioners, midwives, physician assistants, physicians, nurses, to do these procedures. And really, it's the same all over the world. It's the same problem. Not enough people are trained, and it's not super complicated, but it does take some training. So we do the same thing in many, many different parts. And I think you had mentioned that there aren't enough nurse practitioners, especially in rural areas, doing these procedures. So that's been a lot of our work over the last decade. I just want to talk a little bit about Mozambique, because that's where we have a really big project in collaboration with Rice. Mozambique is in sub-Saharan Africa, right next to South Africa. It has a population of about 33 million. There are many, many languages there, but the official language is Portuguese, which causes them to be a little bit isolated because most of the surrounding countries, the official language is English. So they rank 184 of 187 on the Human Development Index, so it's a very low resource country. And cervical cancer is the #1 cancer. So again, not even in the top 10 in the US, somewhere around 15 to 17, depending on the year. But there it is the #1 cancer. And studies have shown that very, very few women have access to screening. And then the other complicating factor is that the prevalence of HIV is high, 13.3% nationally, and in some urban areas, more than 20%. And we know that women living with HIV have a six-fold increased risk of cervical cancer, and particularly if untreated. So that sort of all comes together to have, a huge problem of very high rates of cervical cancer. So how did MD Anderson start working in Mozambique? We were approached by the First Lady of Mozambique back around 2013. There's a coalition of First Ladies of Africa against breast and cervical cancer, and now prostate cancer as well. And they had held a meeting. They heard we were a large, well-known cancer center, and said, please come and help us figure out how to address our cancer problem, and particularly in cervical cancer. And so fast forward, we've been there for a long time. So you can see there's actually 3 different First Ladies in this photo. And it's been nice that they've sort of passed that along as an area of advocacy for the First Ladies. So that's how we started going there. But when they first asked, I said, well, I don't speak Portuguese, and I'm not sure where the right people to, go halfway around the world to help with this. But they really wanted us. But fortunately, we were already doing a lot of work in Brazil. So we reached out to our Brazilian colleagues who speak Portuguese. And you can see here on the left, Jose Humberto, who's a gynecologic oncologist, who at that time was at Barretos Cancer Hospital. We heard earlier about Barretos today. But one of our first studies in Brazil was to bring the HRME that I showed you out to the patients, because the women were getting screened by a mobile van that Barretos had, but if they were positive, then another van they had to come to the Barretos Cancer Center, which sometimes was, hundreds, if not thousands of miles, and then they certainly weren't coming. So the idea was to bring the diagnosis to them. So this was a van. Somehow the NIH let us buy a van. Our institutions let us put our logos on it. Looking at it now, I don't think that could happen today. But it was a great study looking at HRME. And of course, it showed that if you brought the care to the women, the follow-up rates were much higher than asking them to travel. And then on the right is Mila Salcedo, who was a visiting professor with us at MD Anderson from Brazil, and we had formed a great research collaboration with her. So we said, okay, Mozambique is asking for our help. Let's do this all together. So that's how it became the Texas, Brazil, Mozambique collaboration. As I said, we work a lot in the area of policy. I think the longer I do this, the more I see how crucial that is. There are lots of speakers this morning that spoke about it. And the first thing is just to make sure the government's interested in cancer, right? They have a lot of competing priorities. So to have a cancer control plan, and even better is if they have a cervical cancer elimination plan. But Ellen Baker from our team, who's here, worked really closely with the Mozambican government, as well as representatives from UN agencies, and really went through the very tedious process with them of developing this plan that is so important. And you can see here the First Lady launching it, and then Ellen holding the paper copy of the I think the executive summary of the plan, because it's much longer than that pamphlet. But I think really, really important, our strategy at MD Anderson is that we work only in a few countries, and we work with the Ministry of Health to make sure that they're totally on board with whatever we're going to do together related to cancer. And then we do a lot of research, and so we've had great studies in Mozambique with our colleagues from Rice, sort of implementing screening with HPV testing and doing the evaluation of the point-of-care HPV tests, and then doing the multimodal imaging and the HRME. So you can see here, the first picture is with the nurse Sakina, who this one room is her clinic where she does everything, right? She does newborn health care, she does family planning, she does HIV testing and counseling. And then we said, okay, now add cervical cancer screening as well. and just amazing to see the work that can happen. And then Chelsea was one of the PhD students in Rebecca's lab who spent a lot of time in Mozambique, really helping to get the lab up to some quality control, and then be able to do some of either the commercial HPV tests or the rice tests. And then lots of work on evaluating the multimodal imaging as well. We currently have two big studies together in Mozambique, and one is the Avanzo Research Consortium, and we were very fortunate to get a U54 grant from the NCI. And this is an alliance between Mozambique, Brazil, Texas to advance novel technologies for cervical cancer prevention and diagnosis, specifically in women living with HIV. And so we're actually going to do parallel studies in Brazil and Mozambique. And obviously the resource levels are different, the challenges are different, so really to learn from both places. We have two research studies, one looking at the multimodal colposcope developed here, and then also a novel optical microscope, deep DOF, so that we can actually get point of care diagnosis and even margins for our LEAP specimens, et cetera. And then part of that is also to look at the barriers and facilitators of screening and follow-up to care. I think a really nice part of this U54 grant is we have a developmental core where we're really focused on building research capacity. So that includes some small grants, seed grants for young investigators, both in Brazil and Mozambique. And the only rule is that they have to, the primary investigator has to be from either Mozambique and Brazil, and they have to work either with each other or with Rice or MD Anderson. So a great way to try to build some capacity and get young folks interested. We did also an all-day seminar for them as well, have had some echo sessions and other things to try to keep them engaged, help them figure out how to write grants. And we're going to the aortic meeting, which is the African Organization of Research and Training in Cancer. They have a biannual meeting, and it's later this week, and our three young investigators who had grants are all presenting abstracts there. So really exciting to see that move forward. And then we have a study called the Phil study, and many of you may know Phil Castle, who we have both worked with very closely over the years. But this was sort of his baby of doing a randomized clinical trial to compare thermal ablation versus LEAP in women living with HIV who have high-grade cervical dysplasia, because we think there's a chance we may be under-treating them. So Phil has been working on this for a long time and was able to get an R01 in collaboration with us. And then when he moved to the NCI, he couldn't be a primary investigator. So that was transferred to me, but we work really closely with him on this. And it's our first randomized study. And it's been very exciting. We use REDCap and are able to push the button and see where they get randomized to. And we're able to do this in a pretty low resource setting in Maputo. So it's been exciting to have that study going, and we ended up naming it after Phil, given all his work on it. And then, of course, as someone, I think Isabel and others have said, we can screen all we want. If we don't have a plan for the patients with the women with the abnormal results, we actually haven't made any impact. So we do a lot of teaching with didactic learning and hands-on training. And I love the picture on the left. It's in Mozambique where, where Mila is likely asking the questions of, whether treat or not treat. And Brady Hunt, who was a PhD student, the tall white guy in the back, I think it just shows that the Rice students are there evaluating their technologies and doing everything, but they are part of everything we do, including all the education and training. So it's just been really fantastic to work with the team there. So we do a lot of in-person training, but we can't be there all the time, and certainly during COVID we couldn't, so we build on all this with the Project ECHO program, which is extension for community healthcare outcomes. It was developed at the University of New Mexico, and essentially we're on Zoom with the team there regularly, whether we're working on prevention or invasive treatment. We do it for breast cancer, we do it for cervical cancer, but it's really like our tumor boards that we do at MD Anderson. We review cases with them. It's all de-identified. It's bidirectional learning, and really trying to stay connected, continue to support the providers. We do the same thing in Texas as we do in Mozambique, different languages, different time zones, but the same mark. And then if patients actually develop cancer, we have a whole training program through our International Society of Gynecologic Cancer. And here you can see our Brazilian colleagues with our team trained the first 3 GYN oncologists in the country of Mozambique. So if patients have invasive cancer, we now have a way to treat them. And then I just want to bring this back to Texas. All this work that we do in Mozambique and in Brazil, we also do very similar work here at home in Texas. The team from Rice is at MD Anderson when we're in colposcopy clinic, evaluating their HPV test. But also we've had a lot of great work done in the Rio Grande Valley and other places. We have a program we've been running for 10 years with 14 different community clinics and mobile vans around the state to improve their community education, screening, and then very importantly, that patient navigation to treatment, and then make sure folks that there's providers in these clinics who know how to do colposcopy and biopsies and ideally LEEP. We have a lot of studies going as well, especially related to self-collection that Mila Salcedo and Jane Montealegre run, as well as some where we've tested the technologies. And you can see here, the bottom picture is one of the mobile vans in the Rio Grande Valley with Paul Toscano, the PA who runs it, and a much younger version of our whole team, as well as some of the former Rice students. So again, cervical cancer, completely preventable cancer. We have the tools, and we just need to get the tools to all the folks. We're now trying to do a little bit of copycat with Alabama, and Melissa Varone, who's here today, along with Jane Montealegre, Susan Parker, and others from our team are working on developing a cervical cancer elimination plan for Texas as well. So I'll end there, and thank you very much for your attention.
How do you think about scaling this and expanding this? How much difficulty is there in adapting it to different environments, whether that be a rural location versus more of an urban location versus a Portuguese-speaking country? I mean, I guess how much of this can just be copy-pasted, and how much has to be reinvented every time you enter into a new area?
I would say for our work, a lot of it can be copy pasted because the treatments and the what we're doing is the same. What can't be is kind of the partnership and the engagement. So I think more than anything, rather than us going in and doing training, doing that is trying to get a really good understanding of where they're at, what they want, how much political will there is, what they want, what they don't want. And I'll give you an example. We were asked to help the Kenyan Ministry of Health with their training, and so they wanted us to come and do like a week-long, train the trainer, work with their teams, look at their materials, and kind of evaluate it. And we said, okay, we're happy to do that, but we also want to go to the hospital to see what's happening. And they said, okay, and then they said, well, maybe we can go to the hospital on Thursday, Friday, and really pushed and said, no, the first thing I want to do is go to the hospital so I can see what equipment you have, what you don't have, and talk to the nurse who's working there and kind of see, because otherwise we spend a whole week making a plan that doesn't actually fit their situation. So I think that the tools are the same. There's a little, again, language and preference, but cervix cancer is not that complicated. It's kind of the same thing. It's just kind of all those things around the edges that we have to figure out.
I think government, like So we did this, actually, the Alabama, we started in Sri Lanka and with the Rotary Club there. And the whole country changed guidelines because of the negotiations and the influence of Rotary clubs there. But if government does not get involved, we're working in Guatemala now, we're having a hell of a time. And I'm a Rotarian as well. That's my other role. So is that if we're not going to go in, if the government does not have a skin in the game, I think it's very hard to do anything. We are working in the Pacific Islands. It's the same thing. And if it is, research or whatever, I think government is critical, including state. I think, having a state health officer here on board for the plan is critical because then it makes it official and they do have a skin in the game and it costs them almost nothing a lot of times.
My name is Monica Patil. I'm in pediatrics at Baylor. And my question is actually for Dr. Schmuller. I wanted to know, you talked a lot about screening, point of care screening, and rapid treatment for your projects in Mozambique. Where did you fall with talking to the Ministry of Health or the government about vaccination? Is that something that is in the plan? And particularly if you experience any barriers around vaccine hesitancy for the population?
Yeah, it's a great question. So definitely the first part of every conversation about cervical cancer is related to vaccination. But what I would also say is that we at MD Anderson are not public health specialists on a large scale. So we are huge advocates, but there are many, many groups that do implementation of HPV vaccines. So we really try, most of them are already connected, but to connect them. So Mozambique has implemented the vaccine. And we do what we can to support, but it's just not our primary work. But yes, 100%, we're very much behind it. In Texas, similarly, we did a lot early on with being a strong voice about the vaccine. We still are. And then we worked really closely with Ana Rodriguez, who was at UTMB, a gynecologist at UTMB, who was running an in-school, middle school vaccine program that's still running now. That's been really, really successful in Rio Grande City, in an area that has some of the highest cervical cancer rates. And similarly, we got almost no pushback. I mean, I remember going down when we launched it. It was years ago before COVID. And I was so worried. I was like, MD Anderson's going to be all over the news. There's going to be all this anti-vaccine, and there was almost none. The parents just wanted to know if it was free. We did it at the start of school when the kids came to pick up their schedules and their gym uniforms. And again, the only way we could do it was because the superintendent was 100% on board. We tried to do the implementation study here in Houston and HISD and others where we're not interested or able to do it. And so we did it in Rio Grande City, and it's still running probably 15 years later now. And now we're combining it with screening of the moms.
Let me make a comment about Sri Lanka, because it was the same thing. Of course, you need to talk about the whole continuum. And then the government said, how about if we make vaccination at schools, most countries, the countries that have been more successful are school-based, hands down. And a lot of other countries, the US, where we are a little behind, they are doing one dose. So that helps. With the school, you do one dose and you are done. And I remember the Minister of Health in this meeting said, we're going to do opt-out in schools. And meaning the parent needs to sign if they don't want their child vaccinated. And we, the US team, said, wow, if that works here and works perfectly there. So you never know. You need to listen, and they'll come up with ideas. I mean, imagine an opt-out in the U.S. It would never work, but it works in Sri Lanka. So.
Very good. Thanks. We have 2 minutes left, so maybe Rebecca, you could just ask your question, and we'll wrap up.
Well, thank you both for your really inspiring work. My question is for Isabel, because you said something that I found really intriguing, which was that you're glad that you didn't have grant funding for this project. And I wonder if you could say more about what has been good about that and what has been a limitation of that.
So this is not research. Operation Wipeout, I'm a researcher. I have been a researcher all my career. It's not a research program. That was number one. And the community was very happy about that. They said our community, especially rural, have been researched to death, and nobody comes back with the findings. And we said, this is not research. So that, I think, is a number one. So that's why grant funding, it's not. The other, I think it's because there is nobody with a pot of money that people cross their arms and say, well, they will do it. We say, you do what you can. Nothing is too small. Now, for Chambers County, for the work with the high school, I did get a supplement from NIH, actually, because they had money left, the typical. And it's just a matter of me turning that into kind of a research. Don't tell NIH. But so I think that to us has been this success. So for instance, like the summit in January, the Rotary Club of Birmingham said we'll host it. Now, Mobile want to host it, so the Cancer Center there said we're going to host it. We can. So I think that, and everybody owns it if they want to raise. We don't do fundraising, but a nonprofit can do fundraising for their activities. So I think it's a different model. It's a more a Rotary model, but it's because we purposefully are saying it's not research. The research has been done. We know what works. Now we need you to be the messengers. And for Rotarians, in particular, the polio analogy works very well because Rotarians have been working on polio elimination since 1985. So I think that was the right mix with Rotary being the civic organization, government, and us, the academic center, to show that everything is evidence-based. I think that's the kind of the secret sauce.
Okay, one more question.
I can do later, no problem. But Mila Salcedo from MD Anderson. So my question is from my Brazilian friend Isabel. You know that we have bias because we work a lot with training and education, and Kathleen showed to everybody. But my question is, we think from the pillars that you showed for the elimination, we really think the last one, the third one, is the hardest one to achieve, to treat everybody that is positive, because we know all the difficulties for the patients to come back, and also to train everybody. If you have a piece of advice, how you worked in this direction in your state, we really appreciate.
In a way, that has been our easiest piece, because we have now the traveling nurse practitioners who do the colposcopy where women are screened, and the early detection, the Alabama Breast and Cervical Cancer Early Detection, government again, has a dedicated navigator that immediately puts them on Medicaid and makes sure that these women, are follow up. And then we have the cancer centers, Mobile or Alexander sitting in us, Huntsville, depending on they are, that accepted. This is part of the initial partnership too, because before we launch the plan, we need to make sure that we can take care of the problems we found out the way. So these cancer centers across the state, Tuscaloosa, that is MD Anderson, they agree to take care of these women. So actually, that has been the piece that we figure out first. Our hardest one is vaccination. That is still low. That is, I think that's the one we're having the hardest time, actually, in my opinion. So we'll see, because as you know, incidence and mortality data will take a while, because some counties like Chambers, 65% of the cervical cancers there are advanced. So we need to see if the third piece is working. But we have an amazing gynecology, oncologists across the state who said, just bring them to us. And they are really doing their part. Even if the woman is on hold for Medicaid, they'll treat it, and then we'll figure it out later. So that part has been the easiest.
Great, thank you. We have an amazing too.